All right, I think we are at 2 o'clock, so I'm going to get started here. Thank you, everybody, for joining us this afternoon. It looks like we've got a great attendance and a couple of great presenters that are going to be working with me today. So I'll start off by introducing myself. I'm Corey Ryan from Altarum Institute, and our webinar today is The Value of Health, Measuring the Economic Impacts of Prevention, Treatment, and Social Determinants. My co-presenters today are Rebecca Morley and Len Nichols. I'll be giving a little bit of a quick introduction to the process here and then pass it off to Rebecca and Len to give some of their comments. I'll conclude with some comments near the end of the webinar, and then we'll leave hopefully 10 to 15 minutes for questions. You should be able to add questions into the chat box on the computer as we go, and then I will attempt to curate them and pass them along as best possible. So thanks so much for joining us. So let's see if I can advance the first slide. And that's me. We've got introduction slides. We will make slides available at the end of the webinar. So feel free to read these as we pass them along. I won't waste time introducing our fantastic co-presenters. So let's talk about the value of health within the U.S. healthcare system. I think I want to start today just by kind of framing the problem of we have a system today that is very well designed to diagnose and treat acute conditions. It does a great job of identifying problems, working with individuals, and bringing them through treatment and recovery in a short process. The current system, however, is not very effective at managing chronic conditions and particularly poor at making long-term investments in health for the country and individuals. And so what we end up with is we end up with this long list of things that we would like to do, that we would like to invest in, that have large, significant societal benefits, but we can't make those investments very well because those benefits take a long time to show up, and they accrue to a wide variety of stakeholders. So it's very difficult to get any particular entity to make a significant investment in improving population health because they might not see all those benefits. You make an investment, for example, if you're an insurer, and who knows how long that individual, that enrollee is going to stay on your plan. So you make an investment into their health, and you don't see all the benefits. Or you're an employer who makes an investment, and who knows how long that employee is going to stay with you. And so it's very difficult to make those types of investments. And those benefits accrue both to individuals, they accrue to employers, they accrue to the healthcare system more broadly. And so it's really all about how do we convince the public that these are valuable interventions and changes that should be made within the healthcare system. And so that's really what we've tried to do with the Value of Health tool, is provide a way to show and demonstrate evidence of upstream investments in improving public health, improving treatment and care of disease, and really trying to demonstrate both the magnitude of those impacts and who those benefits show up to. So the Value of Health tool is used to synthesize existing data about the economic impact of public health problems and health outcomes. And so when we're talking about well-defined interventions that could be made to solve and improve public health, there is a great amount of evidence that's done, or a great amount of work that has been done in identifying there's a great amount of work that can be done identifying the particular outcomes on things like health, healthcare spending, morbidity, mortality, and how and when those benefits show up. Where there's less evidence is on the particular economic impacts that accrue from those outcomes. And so we're talking about things like how improvements in health change earnings, how improvements in health change impacts on government spending on healthcare and non-health related outcomes, and finally, how those benefits accrue to society. So how improving someone's health might improve their life in such a way that they see economic benefits. And really being able to quantify that is something that's really important to try and advocate for improvements in public health and public health interventions. So you see here a little bit of a graphic of what the Value of Health tool does, and it's really the ability to synthesize these very complex and disparate inputs, things like morbidity and mortality, healthcare costs, earnings, and incarceration costs, and transforming them into outputs that then can demonstrate economic value. And so we're looking at the dollar value that accrues to society, to the federal government, the state governments, and also potentially to employers and the private sector as well. And so by being able to quantify what those impacts are and how the interactions of those individual components combine to produce an economic output can be both particularly effective at advocating for interventions, but also can be productive in identifying and selecting among a complex set of interventions when you have the option of making a decision. And so the Values Health tool is great both at displaying those results, as you'll see from work that Rebecca is going to show and work that I will show later on, and also in synthesizing and creating a greater understanding of how to solve complex and difficult public health problems. So Rebecca, I think I'm going to pass it to you. And here is Rebecca Morley, who is joining us and who previously has done work with us on understanding the economic impacts of childhood lead exposure and looking at cost-benefit analyses of particular interventions to solve that problem. Rebecca, thanks a bunch.
Thanks, Corey, and thanks everyone for joining us today. So I'm going to start and just give a little bit of an overview of the problem of childhood lead poisoning, and then I'll take you through some of the results from the work that Corey and Alterum performed for us while I was at the Pew Charitable Trust. So I lead with this because one of the things that I heard in presenting some of the economic analyses before was, with all the numbers, sometimes we've lost a little bit about humanity in the conversation. And so these are images of brains from children, basically, that were exposed to lead, or they're adults now, but they were children when they were exposed. And the images of the brains have these yellow to red spots that are areas with less than expected brain activity. And they're displayed on a normal brain, which would be all gray typically. And these areas that are red and yellow, what's notable is these areas are related to reading and to impulse control and judgment, and it helps to underscore how lead interferes with a child's ability to do well, both academically and behaviorally. So lead really steals opportunities from children, both in school, on to college, and then into the workplace. And it disproportionately steals opportunity from low-income communities and communities of color, which further exacerbates the unequal opportunity that these children face in terms of good quality schools, neighborhoods, and housing. So this provides a little bit of context for why we're working on this problem. And of course, on the heels of Flint and Calumet and other places, we know that this remains a really important issue nationally as well as in many communities. Lead is ubiquitous. It can be found in water, paint, and the dust that it generates, soil, and air. We embarked on this project to really understand what is the state of evidence around childhood lead poisoning and what are the best practices for mitigating both risk, so preventing kids from being exposed, but also responding if, unfortunately, the system has come too late and they have already been exposed to lead. Here are some of the statistics that just give you a little sense of the national scope of the problem. So this is the report, and in about, I guess it was spring of 2016, while I was at the Pew Charitable Trust, we were approached by the Robert Wood Johnson Foundation, and they were interested in making sure that decision makers had the best evidence all consolidated into one place so that they could make informed decisions at the federal, state, and local level. And so that was how this report was born. You can find the report here at pewtrust.org/lead. And as I mentioned, we're looking at both prevention and at response of lead exposure. The methods were comprehensive, both qualitative and quantitative. We used two quantitative tools, both the Value of Health and then the Social Genome Model, which is a tool by the Urban Institute, Brookings, and Child Trends, to look at the domino effects of change in a child's early life on their later life outcomes, like college graduation, teen pregnancy, criminal conviction, and others. Today I'm going to stick with just talking about the Value of Health results, but also you should know that we conducted over 50 interviews, research, looked at about 700 research articles. We also conducted 22 case studies of state and local policies and practices. And finally, we held national listening sessions and 16 place-based focus groups. So it was a mixed methods approach, and it was meant to both quantify the problem, but also provide a deeper understanding of the current context for the problem and what can be done about it. We had a very large team working on this, and so I just want to give some credit to the folks at the Pew Charitable Trust, the Robert Wood Johnson Foundation, The Health Impact Project is a project of RWJF and Pew, and that's where me and my team worked on this. We also had support from Mary Jean Brown, who is formerly the director of the lead program at the Centers for Disease Control. And then you can see our other team members here from Child Trends, Alterum, Urban, Trust for America's Health, and the National Center for Healthy Housing. But wait, there's more. We had an extended team, and I'm sorry you can't see the left panel here, but it's in the report. A National Advisory Committee, almost 40 subject matter experts, many local partners who helped us to convene the focus groups, parent advocates, as well as concerned citizens. So they're all named in the report, and we appreciate their participation. So normally I would go through detail on all of the methods and how we landed on these recommendations, but for today I'm just going to skip right straight to the findings from the economic models, which were really key in this report. There have been over the years many different economic analyses of lead, but to my knowledge, there was not one report that pulled all of the economic analyses together. And so, for example, you might find reports on the effect of lead paint abatement. You might find the effects of lead on school and some of the quantified benefits of that. But nothing that we could find actually put water, paint, soil, air, all into one particular report, and that's what we sought to do. We also wanted to update the evidence because, as you probably know, lead rates, the rate of children exposed in the United States has come down dramatically over the last decade. So the economic benefits of response are probably lower than they would have been 10 or 20 years ago, but they're still considerable, and you'll see that here. So this is the top line finding from the report, which is essentially an $84 billion benefit for keeping blood lead levels under 2 micrograms per deciliter. And we selected that because we felt that that was the level at which the evidence supported we could get to at this point, and a variety of other details that had us to select that cut point. But in any case, $84 billion, you could kind of think about this as the reverse, which is failing to act would cost the country $84 billion. Now, importantly, this is the costs and benefits for one cohort, one birth cohort, children being born in the year 2018, we assumed, which was the year closest to the data that we relied on from the Centers for Disease Control for our calculations. This is what that data looked like in the report in table form. And I think, as Corey was describing earlier, we look at both different stakeholders. So you can see here the share of benefits to the federal government, to state and local, and then to households. And you see them broken down by health savings, education savings, and then quality adjusted life years. And I'm not going to get into the details of each of these line items, but Corey will be on later. And so if you have follow-up questions about these data specifically, Corey is absolutely able to answer questions. And maybe before I go on, let me just say that we have a table like this one for each of the interventions in the report. For example, for lead service line replacement, for lead hazard control. We also looked at the benefits of eliminating lead from aviation fuel. You may not know, but lead is still used in piston engine aircraft at many small airports around the country. And also for the enforcement of an EPA regulation that requires lead-safe work practices to be used during renovation, repair, and painting. So we have tables similar to this in each chapter of the report that deal with each of the different sources. Next, let me just say a couple things because, as I mentioned, there are previous cost-benefit analyses that have been performed. What's different about this one is that we have used the most recent blood lead level data from NHANES, CDC's data on blood lead. We have updated the relationship between IQ and blood lead, and I should just say that IQ drives the findings in these analyses, so that relationship is very important. We looked at the benefits of multiple policy interventions instead of just one. And then, as I pointed out, we're looking at just one birth cohort. So I just want to suggest using caution when you compare our analyses to others that you might be aware of. This is just a little bit of 101 on cost-benefit analysis. And generally, maybe I'll make one point that I learned through this process, and I have to say, just as on a personal note, working with Alterum was fantastic because they didn't just perform the work for us. They did the work, but they also helped us kind of build our capacity to understand what the work meant, what went into it, what went out of it. In the end, I'm sure I couldn't do as expert of a job as Corey in describing the results, but I can hold my own. So that was an accomplishment in and of itself. And so one of the things that Corey taught me was the difference between ROI and cost benefit. And what we've provided here is not an ROI, it's a cost benefit. Cost benefit ratio is how we actually present the data. And the distinction very simply being that with an ROI, you're looking at the person that put the money in getting the money back. But with cost benefit, we're looking more broadly at an intervention being done by someone or paid for by someone, and the benefits being shared by multiple stakeholders. And generally, in the government, we look for positive net present value of the interventions and try to avoid programs with a negative present value. And there's a whole school of folks that probably would debate whether this is appropriate and the cost of this problem specifically led on children and society. But we should acknowledge that OMB and other actors in the government do rely on these data to make decisions about programs. The good news for us, good and bad, I would say, the good news is that this interventions around childhood lead poisoning very definitely deliver a positive cost-benefit. And the bad news, of course, is that kids every day continue to experience the deleterious costs of this problem. All right, so this is an example of one of the interventions, obviously a very high-profile one, lead service line replacement. And you can see at the top that we figured out the number and the percent of children that would be affected by this intervention, what is their starting average blood lead level across the country, and then how might we change that blood lead level if we intervened through a full lead service line replacement. And we used two different starting water lead levels there. You can see 11.4 or 5, just to see how sensitive these results would be depending on the starting, the baseline conditions, if you will. We figured out how many homes would require lead service line replacement and then the number of children in those homes that would be affected. And we figured out from the literature how much decrease in lead in water we could expect from this intervention. And you could see the 9.4 and the 3 reduction that we would expect. And then we figured out how much prevented blood lead level increase you would have. I know that's kind of hard to get your head around, but we're trying to figure out how to keep kids' blood lead levels from rising in this particular scenario. And then we figure out, and when I say we, I mean Corey, the impact on earnings, health savings, education savings, and QALYs, both for that initial cohort, and in some cases we looked at future cohorts. So you can see here the costs or the benefits for future cohorts, and then the total gross benefits. Then from there, we break down those future benefits to state and to the federal government, state and local, and to the households in the private sector. So that's essentially what we did for each of the interventions. And I'm not going to do this table for every intervention. I'll just give you the upshot. This was the upshot of the lead service line replacement. So 350,000 children protected, $2.7 billion in future benefits, or about $1.33 per dollar invested. And again, that's stated as a cost-benefit ratio, not a ROI. So I mentioned earlier about EPA's renovation, repair, and painting rule. And this is that intervention, and you can see here that enacting that policy or enforcing that rule would protect about 211,000 children that are born in 2018. And then you can see the future benefits and the very robust return on investment, or the very robust cost-benefit ratio of $3.10 per dollar spent. Some of these quotes on the screen here, just FYI, are from our focus groups that we conducted across the country. Lead paint hazards, you can see here for remediating paint, dust in homes, older homes of low-income families would produce about $3.5 billion in future benefits, or $1.39 per dollar invested, and protect about 311,000 children. So again, if you're wondering how is it that it's 311,000 children, some of the factors in there are that we focused on pre-78 housing, primarily. In this particular statistic, we focused on pre-60 housing, which is even more likely to have lead-based paint, and we focused on low-income housing. So we're really targeting. And of course, again, this is one birth cohort plus some children that we think will be born into those homes over time. So I wanted to just give you a flavor for how this information gets used in the media. You can see here that the lead, my husband's a journalist, so I can talk a little bit about the lead here. This first paragraph of a story is always really the most important. It sets the tone for the rest of the document or the rest of the article. And this journalist chose to lead with the cost-benefit information. And so did this journalist and this journalist. So I think what we really did by providing this cost-benefit information not only gave policymakers valuable information, but we also provided a really good hook for media to cover it. This is what's different. This is what is interesting. This is what's been learned through this. And certainly later in the story, we oftentimes will see quotes from affected families, a little bit more about the local flavor, but they're leading with this cost-benefit information. Other ways that we use the information, we spoke on the Hill. This was in the Senate this fall, doing a briefing for Hill staff. I'm joined here by John Auerbach from Trust for America's Health, Giridhar Mallya from the Robert Wood Johnson Foundation, Dave Jacobs from the National Center for Healthy Housing, and then Kathy, and I'm just blanked on her last name, which is terrible, but she is leading the efforts in Cincinnati to make lead service line information more public. They're really a leader. So let me move to the next slide. Next steps. All right. I'm actually not going to share with you what we're doing next, except to say that we're so pleased with the work that we did with Alterum and found the results of it so useful that we wanted to continue the relationship and continue the information gathering. But one of the things that became identified as a need during the course of this work was the states and localities felt like they really needed information at their level, that the national estimates that we provided were good, but they needed to make a case to their mayors or to their governors, and so there was a widespread agreement that we needed state and local calculations. So that's what Alterum is up to next, and I'll let Corey describe that when he speaks. So with that, let me wrap and thank the organizers for having us. And it was Kathy Bailey. Sorry for forgetting her name, our friend from Cincinnati who's done amazing work on lead. Thank you.
Fantastic, Rebecca. Thank you very much. Len, I'm passing to you.
Okay. Thanks for having me, Corey, and I'll skip that. We'll just go straight to why I'm here, which is to make a plea for why we need local estimates of the many costs of opioids and other drugs abuse. Basically, my takeaways are quite simple. You know that there are many dimensions to the cost of drug abuse, and particularly the opioid crisis that has gripped our nation. Therefore, you've got to use system or social determinant type of thinking to address it, and the fundamental bottom line is that we're not going to be able to divert resources at the local level unless we convince state and local leaders of the costs that accrue to them from, you could say, doing nothing or doing what they're doing now, business as usual. Because they're going to have to divert dollars and invest them in order to save people, communities, and ultimately money in the long run. These are, if you just think hard about it, these are the costs that are always going to flow from opioid addiction and its things that follow it. And I lay them out in 3 time frames. You can see, in a sense, as we go, as the person progresses through time, immediately you lose work and the productivity that comes from that, and the income and taxes that you pay. If you die, we lose it. I'll come back to that. If you don't die, we still lose it while you're being treated. And of course, there are the medical emergency costs, criminal justice costs, and typically family service supports kick in a lot of cases. You move to the middle and you've got everything we had before, but we pick up addiction treatment, which is how you're going to actually try to move the cavity in the person's soul so they won't come back to this drug. But if you go long term, you still have work loss, you still have everything else, but you have repeated treatment because treatments don't always work the first time. In fact, it's quite common for people to have to go through it a number of times. And the last little bullet there actually picks up on the previous presentation, because a lot of what I think we have not yet done, and I will say the best people who have estimated this are the Altarum team, led by Corey. Their team at CDC did some prior work on which he built and improved. But I don't think anyone has looked at these long-run costs to, in particular, children of addicts and people who are affected by the opioid addiction process. And those long-term costs may end up being large. At the moment, we think the largest long-term cost is the lost productivity from earnings. And just to put that in perspective, if someone, say at 35, overdoses and dies, we lose 30 years of work. If they make as much as $40,000 or as little as $40,000, discounted over the future 30 years at 3%, that's $784,000 of lost income, which has sequelae across all of society. So it really is huge when you think about the cost of life. So when you think about trying to solve the problem, it obviously makes sense to do this system thinking, and this is a fairly standard diagram of determinants of health, and you'll notice only two of them have to do with healthcare and or biology and genetics. Everything else, pretty much the social environment and or the economic environment or the physical environment in which the person and the family and the community find themselves. The people who I think have done among the most interesting work that's being done in trying to address the opioid problem truly as a system are the people down in North Carolina who've come up with this Project Lazarus, and there's a URL there, and I highly recommend you go check it out. But if you look at the ways they have begun to address the problem, first, harm reduction, how to keep people alive. Second, addiction treatment, community education, provider education, coordinating the hospital ED with criminal justice diversion control. But of course, don't forget, these people are there because they're trying to manage pain. So we've got to figure out how to manage pain better. And basically what the Lazarus people have learned and what people are learning around the country is none of this works unless all of it works. You're not going to get people cured unless you take a systems approach. The following slide just has a bunch of sort of pictures to try to drive this home. Start in the upper left-hand corner, and you've got the discovery of the overdose on the ground, going through the emergency system, typically, certainly with an ED visit, maybe an admission for a few days, oftentimes end up in court. And you've got the family support kicking in. Hopefully the addiction treatment kicks in, and that enables you to move back to the lower left-hand corner where we can get you back to work and hopefully wrap enough services and new way of thinking around you and your family and your community to make you resilient so you don't go back into the cycle, which has happened far too often. For this kind of system work to occur, what we really need is a map, and we need to be able to account for all the cost connections that those, hopefully, pictures just reminded you of to see what this current status quo is costing us. And then we can use that local map and that local accounting for the various dimensions of these costs to convince local leaders that there are better ways to divert their spending and to improve outcomes, because fundamentally which investments are going to have the highest ROI or cost benefit, whichever way you want to look at it, will depend upon local conditions, local assets, local challenges, and that's where, in my mind, what Corey and his team did in Lorain County, Ohio, is so instructive for us all, because they show very clearly what those local opportunities and costs are. So I'll stop there and be glad to take questions as we go along.
Fantastic, Len. Thank you very much. So I will dig a little bit into the details of the Valley of Health tool in particular and the capabilities that we have developed here at Altarum through a broad range of projects. And you can see here we've done work looking at early childhood interventions, specifically education interventions, smoking prevention and obesity prevention interventions. We've done some preliminary modeling and published some comparative analyses of different interventions on those two topics that I will demonstrate and show to you. The work that Rebecca has talked about and some ongoing work that I will talk about dealing with childhood lead exposure and prevention. and also some work that we've done here at Altarum looking at the opioid crisis. And so really my goal for the rest of the presentation is kind of get into the nuts and bolts a little bit of the types of results that we can show and really how I think they can be useful when being applied to both advocating for some of these problems and interventions, and what really we can learn from these types of analyses. And so we'll start here looking at what really is one of the key outputs of the Value of Health tool, which are these graphs that can show impacts of interventions over a very long time horizon. What you're looking at here is you're looking at the dollar impact on the vertical axis. So if you start at the left, you're looking at dollars and billions of dollars. And on the horizontal axis, you're looking at the number of years out into the future. So basically you're saying the number of dollars that we're going to see in benefits or costs and the years in which those occur. And so the black line is the sum of those benefits in each individual year. So when we're looking at smoking, an example, smoking prevention, and this was both the smoking prevention and obesity prevention interventions were a particular modeled intervention for a small cohort of individuals starting at age 20, looking at the impact and the benefits that it would have over the lifetime. And so as I've discussed, the Value of Health tool is incorporating impacts on health spending, on earnings, on incarceration, and also looking at impacts on, including impacts of education as well. And so what we're seeing here is the impact of smoking prevention in value to the federal government. So I'm specifically calling out in these two charts here, values to the federal government. And so you're talking about primarily increased tax revenues that are resulting from increased earnings, either from living longer or being healthier and more productive in the workforce, or you're talking about reductions in federal expenditures on healthcare spending, and which is primarily coming through as decreased spending from Medicare and Medicaid. And then also, you see also highlighted in red what we're labeling longevity impacts, which are the impacts of the fact that individuals live longer, and so the fact that they're more likely to be also receiving Social Security and other federal assistance benefits as a result of living longer. And so you can see here what we're able to do is we're able to compare and contrast these two seemingly similar interventions for a similar population of individuals, and how those interventions might differ in the types of benefits that we see over time and the magnitude of those benefits. And so this is the type of analysis that both helps inform what types of interventions we might want to support, but also can give us a greater insight into predicting what the impacts will something be over a long period of time. And I think the Value of Health tool is unique in that it really is targeted to look over this extremely long period in which a lot of analyses typically don't take account of, because a lot of times, and the lead prevention example is a good example of this, those benefits do take a long time to accrue. So if you just look at the health impacts over a 5-year or a 10-year period, you're really not going to do a good job of capturing the total benefits that might occur from a societal standpoint. And that's really what we're trying to do here, is give this long-term picture of look at the value you can have to society over a long period of time. Skipping ahead here to the work that we've done looking at the economic cost of the opioid epidemic. I'm flipping the script a little bit in that I'm only showing the cost of the epidemic. So far, the work that we've done in this area has not looked at particular interventions, unlike the smoking and obesity prevention, which we're particularly looking at a targeted intervention to solve that problem. The work we've done so far with opioids has specifically been targeted to identifying the costs of the epidemic and using that as a springboard to hopefully provide evidence that this is a problem, provide a greater understanding of the problem, and also in the future allow us to do targeted analyses of specific interventions. And so you look here, of course, these numbers, as we know, are unfortunately gigantic. You're looking at over $1 trillion between 2001 and 2016 in lost economic value as a result of the epidemic. And if we continue at current rates, you're talking about something like $500 billion over the next 4 years. So those truly are staggering numbers. But something that I like to emphasize that I think is really important and really is a key component of what we've done with the Value of Health tool is that while these numbers are eye-catching and oftentimes the numbers that people really gravitate towards, the value in doing this work really comes from actually trying to understand the underlying components. So it's really about what is driving these costs in the long term, and really where should we target the interventions to try and remediate these costs whenever we can identify the particular cases that they're occurring. Because it's not just the total number and the cost that matters, it's understanding the scope of the problem, the methods by which the problem is causing harm, and then where can we target within those pathways to try and remediate and improve the situation. So apologies if the text is a little small. You can see at the bottom here when we're looking particularly at the opioid epidemic, the two red bars are are the driving factor of the cost, and their lost productivity costs. And so certainly things like increased healthcare costs, which you see in the green, are a large component of the opioid epidemic. But when we're trying to actually measure the magnitude of the economic impacts, we're seeing that the costs of the epidemic really are coming from productivity losses, and in particular as a result of the rapid increase in deaths that we've occurred, which is the lighter red, or the fatal losses of productivity that Len mentioned. When you're talking about potentially upwards of close to $1 million in losses for an individual who's dying in the prime age of their life and would be expected to have an average wage throughout their lifetime. You can see the additional components that we draw in here: cost to the criminal justice system, cost to child and family assistance and education. Those are not built specifically within the tool. The tool has a set number of impacts that it's able to capture, but it's also flexible in that we can add these additional components over time or do side analyses to pick up these other components depending on what intervention we're looking at. But looking at productivity losses and looking at healthcare costs are oftentimes the main drivers, and so certainly the tool is well targeted to understanding those components. And then, as Rebecca mentioned, when talking about lead, we also expand and apportion those specific outcomes to who is paying those costs or who is seeing those costs in society. And so you can see here we're breaking up the components between the individuals and households in the private sector and in the lower portion in blue, and costs to the federal government, costs to state governments, and also local governments as well up above. And so you can see here is that the epidemic, as we've measured it right now, the costs are actually primarily centered to individuals in the private sector, which I think is a really notable finding and something that I think should drive investments, because this is really not just costs that we're seeing to institutions and large-scale entities. These are costs to individuals and to the private sector as well. And so that really hopefully helps motivate greater investment in interventions, both on the treatment and prevention and recovery side as well, to solving this problem. And so I think that's really, again, part of the value of doing these types of analyses is understanding and breaking out where these costs are showing up and where. And so, for example, if you're a state government, if you can apportion out the particular costs that are occurring to your state, or if you're a local entity that might be able to show the costs specific to your locality, it makes it far easier to advocate, as Rebecca said, to be able to show that positive cost-benefit analysis, to be able to show that positive ROI for your particular institution can be particularly valuable in advocating towards more dollars. So some future work that is ongoing right now is expanding both the childhood lead prevention exposure examples and the opioid epidemic examples to state and local levels. What we found is that while doing these national kind of total scope estimate type of projects is really valuable, the immediate question that we get from individuals is, okay, what does that mean for me? What does that mean for my state? What does that mean for my county? What does that mean for my particular geographic area? Because while having a national number is impactful and certainly is the largest, it often is not as detailed for what policymakers need. And so the Value of Health tool is designed in a way that is flexible and is designed that can be applied at multiple geographic areas of multiple geographic scope. And so our goal in continuing work on with the Robert Wood Johnson Foundation, looking at childhood lead exposure, is to look at state impacts and also particularly look at modeling the value of doing lead hazard control and lead service line replacement within those states, particularly looking at predictions of what are the major drivers of the lead burden within the particular states and where it might be most valuable to target interventions in order to solve that problem. Looking at the opioid epidemic, looking both at state level estimates of the economic burden and also, like I said, beginning to think about modeling potential prevention and treatment interventions, really to think about what are some of the investments that could be made to solve this problem rather than just simply looking at the cost, which is what we've done so far. Other applications that I think are particularly relevant would be looking at the economic impacts of other diseases or public health problems, estimating the societal benefits of particular public health interventions. And I think notable of the Value of Health tool is that it's both been applied and can be applied both to health-related interventions, but also non-health-related interventions. So a good example of that would be some of the very early work that was done looking at education interventions and how those impacts might impact health and earnings and all the other components downstream for individuals over their lifetime. And so that work is really valuable in that we're looking both at the health impacts of health interventions, but also the health impacts of non-health interventions. And I'll talk a little bit more about that in one of the examples here. That's actually the second use case, apologies. So the first use case I want to talk about is what is the value of preventing opioid use and addiction for a particular population? And so really trying to drill down much further than we've done than the work we've done so far, and to try to say what's the value for a particular employer or a particular insurer or even a particular provider in trying to invest both in prevention and treatment and recovery programs in dealing with this opioid problem. So there's a lot of work that's been done looking at the costs, but really very little work that's been done identifying both what the medical outcomes would be, but also what the long-term societal and economic outcomes would be of well-established prevention and treatment and recovery programs, and both being able to identify and advocate for those programs, but also being able to compare and contrast how we might, for example, value the amount of investment we should put towards prevention versus treatment and recovery. That's something that the tool is certainly capable of doing, and modeling different scenarios based on different programs that are available. This is probably a good time to note that the tool is not designed to particularly predict what the outcomes of a program might be. That's information that we curate from expert sources and academic literature and previous analyses. But what the tool is designed to do is able to take those understood impacts of a particular intervention and carve out and detail the economic resulting outcomes from those particular health spending and long-term earnings impacts like we talked about with the tool. And again, looking in this use case to estimate the value of these programs over different time horizons, trying to advocate for the fact that making investments up front very early on in preventing the opioid epidemic might be far more, and we would expect to be far more cost effective than doing treatment and recovery programs on the back end to mop up for the fact that we have individuals who are suffering, unfortunately, from substance use disorder. But it's obviously going to take a combination of both of those to do a complete remediation of the epidemic that we're seeing across the country. And then comparing outcomes based on a variety of societal and epidemic characteristics. So being able to model, for example, based on the severity of an epidemic within a particular region, we know that this epidemic is built up both of prescription drug abuse and illicit drug abuse, and being able to understand how these particular interventions might vary in different situations as a result of what the epidemic looks like locally. Then looking at perhaps the second use case here, how about the economic and health impacts of non-health programs? And so one that's come up that we've been thinking about recently are the economic impacts of food assistance, SNAP and WIC, and other programs that provide nutritional assistance to families, children, and mothers. And really trying to demonstrate the economic and health outcomes that can occur from these programs. We've seen that states are increasingly looking to clamp down on these programs, for example, requiring work requirements in order to participate. And this is something that I think is concerning to us and something that I think deserves further research in the impacts of these programs. And so certainly, again, there's great academic research that has been done in what are the impacts of these programs on health, what are these impacts of the programs on economic outcomes, but not a lot of work that's been done looking at the complex societal benefits that occur from these programs, and really how these benefits occur over a long period of time, and also who sees those benefits. And so that's really where I think the Value of Health tool could play a role in these types of examples of looking at the health impacts of what we would traditionally describe as non-health public programs, but something that clearly has an important impact on health. As Len mentioned, all the impacts of social determinants, very few of them are actually health-related drivers in long-term health for an individual. It's all these other economic, societal, local, environmental components that play sometimes the largest and an outsized role in someone's life. And so looking at how a program like SNAP or WIC might improve the life for an individual and improve their health over the long term, and then the economic outcomes that would occur as a result of that, is something that I think is really important and something that we're hoping to be able to do with this tool. And then lastly, I'd just like to point out that this tool is useful in that it's often, in previous analyses, been combined with other components. I think Rebecca's example of doing both qualitative analyses and quantitative analyses of particular lead policies in particular places around the country is really important, because while these quantitative analyses are particularly persuasive to some individuals and oftentimes are very useful for policymakers, it's oftentimes also important to be able to understand different qualitative factors that might impact where different interventions are needed, or the value of different interventions, or really trying to understand in combination with what the economic impacts are, what the social and community impacts are of particular problems or particular interventions. And so we've employed the Value of Health tool in combination with some other things here at Altarum that can really kind of magnify the potential impact. So I'll point to the Altarum Consumer Engagement Measure, which is a fantastic survey-based methodology to incorporate a measure of a consumer's engagement with the healthcare system and their activeness and engagement with getting the care that they need and the empowerment to be able to get the right care that they need at the right time. And so really trying to combine the Value of Health tool with a measure like this when you're looking at particular problems that, for example, obesity interventions where they require a great level of engagement from the patient in order to be successful, combining the consumer engagement measure alongside the Value of Health tool can reap particular benefits. Looking also at some recent work that we've done with Prometheus Analytics here at Altarum, which is a claims-based episode builder and processing database and application. Again, combining both the medical and claims-based component alongside this broader public health view, economic benefit, and societal benefit view is something that has worked very well for us right now, and certainly I think will pay dividends for us in the future. And so thinking about other components, either in work that we do here at Altarum, is something that we try and do a lot, combining, again, the qualitative and the quantitative components, or bringing this tool to other projects, like Rebecca said, in being able to kind of add quantitative rigor to qualitative analyses that others are doing, I think is something that has been really beneficial for us. So here's a little bit of further information. Again, these slides will be shared to everyone. And so I'm going to kick off a couple questions here for Rebecca and Len. Folks, feel free to add them and type them into the chat box. And I also just want to apologize for those that have been hearing beeps throughout the process here. We pushed the wrong button when we started the webinar here. So for those that are hearing them, I apologize for that. Rebecca, maybe I'll kick it off with you. Do you want to talk about the comparison between the two? You showed two scenarios for lead service line replacement and two kind of somewhat different outcomes as a result of those two scenarios. Do you want to talk about why they were different and what it really meant to do sensitivity analyses when we did that work for you?
Sure, I'll give it a try. Should we switch back to that slide to be able to show folks? Would that be possible?
Sure. Yeah.
Okay. I'll get to the slide and then I can speak directly to the question. But in general, obviously, if you have a lower starting point, then the benefits are going to be smaller. And there isn't a very good source of data to tell you what is the starting water lead levels in the country. We didn't have very good data on that, so we had to rely on best professional judgment as well as some published studies to come up with our two scenarios. So one starting at 11.4 and one at 5 as the baseline. And you can see certainly, you know, if your starting water lead levels are at 5, we think that you can decrease through the full water lead level or the full service line replacement, get down to about 3. The remaining lead, you can reduce it by 3 and then get to about 2. The reason we think you can't get to 0 is because this particular intervention did not include replacing all of the interior plumbing, which also contributes to some of the water lead. But obviously, if you're starting at 5, it looks like you're going to get a total of about $860 million in gross benefits, whereas if you're starting at a higher level, such as 11.4 or 12, you're going to be getting in the billions, 2.7 billion. And so I think one of the things that the additional analysis that Corey is going to be doing at the local level will give us some insights into what this looks like at the state and local level. And to the extent that we can get actual data to feed into these models from the state and local jurisdictions, it will make this even more practical. Do you want to add anything, Corey, to the sensitivity analysis?
No, I think that's great, Rebecca. I think it's an important topic to bring up, that when you're doing this type of modeling work, that certainly there is often uncertainty in the inputs. And so being able to be flexible in what the model can do and trying to demonstrate the range of potential impacts that we might see, and you give a particularly good example there where the lack of data required us to make a range of estimates for what we think the capable levels of lead reduction within water would be, and then we can show how the magnitude of those results vary. And obviously the hope is that you can change the inputs somewhat and not have huge impacts on the outputs. Occasionally that's the case. Sometimes it's also not the case, in which case it's important to report both. So that's why we do that. Len, a question for you. And more philosophical, I think. Can you talk about why are we not more proactive in investing in prevention here in the United States? I think it's the questioner is calling it the wrong pocket problem, and that we often understand that there are huge benefits that we could get, but it's very difficult to get any individual to see those particular benefits and make the investments that are needed. Can you talk a little bit more about that?
Well, thanks, Corey. I mean, since you offered philosophical, I'll start there. We have a libertarian streak that's pretty deep and long, and we think people are supposed to be responsible for themselves completely. But of course, that flies in the face of a whole lot of evidence. So the real reason I think we're not as good at it as they are in Europe and so forth is that essentially investing upstream in any kind of prevention, and as you pointed out quite well, health interventions accrue to non-health actors, and non-health interventions accrue to health actors. Essentially, it's like a public good. It's like something that spills over and affects many different people, and the benefits are diffused as well. So no one actor can often capture the return on investment or to make sure they're going to get their money back. Again, as you said at the opening, insurers worry about people switching plans. Hospitals worry about improving the health of people who then don't go to other hospitals as opposed to theirs. So it has to do with the public good problem. There are solutions to the free rider problem. I'm working on one of them, and I think there are some other people trying to do the same thing. But in general, I think that's why, in my opinion, to solve any of this, we've got to think more systems-wide, do a more complete accounting for the interactions of the cost. And when people do see that, in my experience, they do come around. So there's hope, but we need to think more broadly and more precisely.
I agree. Thank you. I got a question here. I think I'll take this one. Have we had the opportunity to go back and validate our model with real-world evidence? It's a good question. It's an important question. Certainly, validating. There was a great amount of initial work that was done when the model was first developed in looking at particular interventions and then specifically modeling the outcomes that would occur. Although because those were hypothetical interventions, validating with real-world evidence is difficult. I guess what I would say is that what we have been able to do is justify known real-world data inputs, and certainly all the inputs to the model are real-world inputs, and looked at what particular impacts on those outcomes would be, and if they match up with what we see in the value of doing particular interventions. That being said, when you're talking about all the interactions that occur as a result of the complexity, and we're talking typically about hypothetical scenarios, and what would things look like if we were able to do a particular intervention? And when you're talking about economic impacts, you're talking about broad, impacts over a very long period of time. It's difficult to be able to validate the work, but certainly seeing consistency with previous analyses that have been done and looking at individual components and looking at the impacts that we see on individual components, certainly we have done some of that work, and we can share more broadly with the group some of the papers that have been done looking at this problem and the methodologies that sit behind the tool as well. Rebecca, there's a question here talking about, do you think that this work was valuable as far as trying to broaden the scope of interventions that might be available to solving the lead problem? And also, how do you deal with the kind of competing issue in that I think oftentimes there's a support for doing one intervention over another rather than doing both. And do you think this type of work was valuable in trying to help solve that problem, or at least start that discussion?
Oh, that's a great question. I'm going to start with the last part of it first, because I do think providing both the grand sum total of $84 billion, but then also the costs and benefits of all the other individual interventions did help to solve that problem, because it shows that you need to do multiple interventions in order to reap the benefits. From a strictly public health standpoint, it makes no sense to go in and address lead paint hazards to leave leaded drinking water or vice versa. And we've actually seen evidence of where interventions have been done in the home environment to address, for example, lead paint, but the soil hasn't been addressed outside, and then it gets tracked inside, and you've got new hazards there. So, both from a public health prevention perspective and a cost-benefit perspective, it makes complete sense to treat these things holistically. And the way we frame that up for people that would prefer to do one intervention because it's simpler or maybe less costly at the front end is simply to approach it from an effectiveness standpoint. Half the battle is getting into the home. And so making every visit count holistically makes a lot of sense. I think this report probably shined a light on some of the hazards that people didn't know about and hopefully helped people to think about the issues more broadly. I think in the past people have tended to think about lead as a lead paint problem, and we're showing that water is also an important contributor. Very few people had ever heard of lead still being in piston engine aircraft gasoline. So I think we also shined a light on some of the sources that are out there that people didn't know about. Thanks for that question, Corey.
Yeah, fantastic. Len, I'm going to ask a personal and somewhat selfish question. What do you think we can do to improve the availability of data related to the opioid epidemic, and in particular related to potential interventions that are being put in place right now to solve the problem? What are important things that we need to consider as far as data collection and how we can improve the knowledge and analyses of work that's going to happen over the next upcoming years?
Well, I think y'all should do for the country what you did for Lorain County. Just do every county. There's only 3,000, Corey, so you should start this afternoon. I mean, I think showing variation across different kinds of counties, different kinds of economic structures, as you know, different, frankly, mixes of which legitimate drug got them started and which illegal drug tends to predominate in that area, those are going to have very different impacts. And I think the notion of assessing which kinds of interventions, and as you know, there are quite a few creative ones out there. Let's try to get some numbers around this and compare. There's enough going on, you could actually randomize some of it and do a serious evaluation of what interventions, what combinations of interventions have actually reduced cost. And the beauty of your tool is you should be able to measure in both directions, right? Cost and the benefit from doing it. So Godspeed and get after it.
Wonderful, thank you. Last one to wrap us up on here, and this is a question I think for both of you. Rebecca, let's start with you. Is pursuing these interventions more difficult in the current political climate?
Oh, I think that the current political climate is maybe balanced by the national concern and anxiety that grew out of the Flint and Calumet situation. So while certainly the political environment could be slightly more conducive to public health and housing, for example, there's so much public concern and accountability that I think we do have, the aperture is open for action, and so it behooves us to move quickly.
Great. Len?
I would certainly agree that the environment could be better, but I would also say the environment and, if you will, the dysfunction at the federal level has actually engendered a kind of a more determined response on the part of civil society and a lot of local communities, because we've figured out Washington's not going to solve our problem, therefore we have to solve it locally. So in some ways we're more energized and focused than we were before.
Fantastic. Well, I give you all the gift of ending on a little bit of optimism again today. Thank you very much to Len and Rebecca for joining me. This was fantastic. I hope everybody got a lot out of this and learned a bit about some of the work that we've done and work that is being done in this space. So further questions, feel free to pass them on to the email or the phone number that you can see here. We will again be sharing the slides with everybody. And thanks again for joining us. Bye all.